So if you look at the British Thoracic Society, American Respirology, etc., everyone kind of says the same thing. 80 to 92 is the gold standard. But why?
So it's been shown that if you aim for a target above 92, quite simply, in a long-term fashion, you increase mortality for these patients. Our lungs and our system is designed quite intelligently, beautifully, because when you have non-ventilated, non-oxygenated parts of your lung parenchyma, you will cut off blood supply to that section of your lung. We want to avoid a shunt through our system. COPD patients are living like very difficult lives a lot of the time, and they're usually quite short of breath every day. Their ADLs are affected every day. So then, we look at them and say, yeah, like I would be calling 911 if I was like this, but maybe that's a normal day for them. So it becomes a little bit challenging. But yeah, like I guess addressing that part of the disease that is airway reactivity, we can address that with salbutamol, right? Yeah. We can dilate their bronchi with that medication, which will allow for more airflow in and out. Often these patients may not have that much like wheezing because there's not that much airflow to begin with, right? So you might just have decreased air entry throughout. Yeah. And then you give the salbutamol, sounds a little bit better. But then we somewhat recently started giving a steroid. Now that's a very high yield intervention for us, right?
I'm glad you said that, because what do paramedics think when they hear it's not a first-line treatment?
Oh, I don't need to give it then.
Yeah, well, the point of it is for us to give it in the pre-hospital setting. Even if it's not first line, doesn't mean it's not important. It's a super important medication.
Yes.
But it takes a long time to deliver and peak. But that's why we give it as soon as we can, because it's been proven when you give a steroid in the pre-hospital setting, you decrease hospitalizations, you decrease the chance of them being intubated, you could decrease all these morbidity and mortality outcomes.
And I think with the systems level pressures that we're facing nowadays, it'd be easy to say, and I think this is kind of the issue that we were dealing with as a profession, is like, oh, whatever, just get them to the hospital in 15 minutes and they'll get care there. It's like, no, right? I go to this patient's house, I start them on salbutamol, maybe I start a line, I give them dexamethasone, whatever. There's so many easy ways to give dexamethasone, right? Okay, so I gave it to them within 15 minutes of meeting them. Now I get them to the hospital, we do a 6-hour offload delay. I then finally get them into bed in 8 hours. They got the drug in 15 minutes. The way the system used to work, they would have gotten the drug within 8 hours. And since the drug takes hours to work, think of the benefit that we just unlocked for that patient by moving it upstream, right?
Yeah.
And what's, whether this is a good thing or a bad thing, in my practice now with long offload delays, I'm seeing the steroids start to work. Because we're not having to repeat the salbutamol as often. The patients look better, they sound better, they're less crackly, like all these things are improving. It's over hours, but turns out we do spend hours with patients now.
Yeah.
So
let's play like a mind exercise. Let's say somebody needs to be intubated and they're alive. So the priority is the intubation. Secondary is analgesia and sedation. You imagine, it's not first line. I don't need to give sedation, analgesia. Don't worry, but the hospital can do that as they're going in delirious, bucking on the tube and everything.
Yeah, just hold them down, right?
I'll just tape your arms out. So that's why, like, they gave us that drug that matches the evidence. So overall, we can improve the outcomes of patients when we give it in the pre-hospital setting. Like, I can appreciate if your hands are full, you're ventilating them, and so you in the back, you're doing salbutamol. You may not have the hands and resources to do it, but the vast majority of patients, we should be able to fit in dexamethasone. So usually we just do it orally. Preferentially give it orally and squirt it in their mouth.
Super easy.
Super easy, yeah. Super effective, super beneficial medication.
Yeah. Now, there's one other medication that we do give to these patients, and that's oxygen.
Oh, wow.
However, we have to be a little bit careful with this medication, right? Because if I give too much oxygen to a COPD patient, they will go apneic, and then they're going to die.
I don't remember teaching you that.
That's what I was told.
So the hypoxic drive. What is this nefarious hypoxic drive?
Well, what I was told back in the day, which was only like 7 years ago.
Don't blame me.
Yeah, no, that wasn't on you. Was that if I give a non-rebreather with 15 liters per minute and gets a COPD patient with 100% oxygen, they will go apneic and die.
So what is that based on?
So it turns out it's not based on much.
That's true.
Yeah,
it is true.
Yeah. So like what is your understanding of this myth of hypoxic drive? And then tell us a little bit about the truth of the matter. Why don't we want to give too much oxygen to these patients?
So I gotta look at the year again, but I think the research was initially done in like the 40s, which was a very long time ago. And yes, evidence can change. And there was like maybe a correlation, low quality evidence that that was the case. So right now, you and I are breathing because of our central chemoreceptors in our brainstem. We respond to high CO2 or low pH correlates to acidosis.
Yeah.
So that's how we intrinsically breathe automatically. So we know COPD patients have air travel. So that means they're retaining CO2 because they're not breathing it out as the byproduct. So the theory was that, your body needs to adapt. You have too much CO2, you're ruining your intrinsic values to breathe. You're going to switch to low oxygen levels. So then if I give you a high concentration oxygen, I'm not taking away your ability to breathe like that. And so you just suddenly go apneic and die. But the truth is that has kind of gone away. More evidence is emerging that's not validated. And it's not a risk, but it's a very small minority. And usually it occurs long-term oxygen therapy in the in-hospital setting. And it's because of free radicals, the Haldane effect, and just the reversal of hypoxic pulmonary vasoconstriction.
Yes. So like what is our oxygen target for these patients?
So if you look at the British Thoracic Society, American Respirology, etc., everyone kind of says the same thing. 80 to 92 is the gold standard. But why?
So it's been shown that if you aim for a target above 92, quite simply, in a long-term fashion, you increase mortality for these patients. So, our lungs and our system's designed quite intelligently, beautifully, because when you have non-ventilated, non-oxygenated parts of your lung parenchyma, you will cut off blood supply to that section of your lung. So that's to avoid, if you think about it, we want to avoid a shunt through our system, right? And a shunt is I'm taking blood from my right heart, I'm putting it in my left heart without it being oxygenated through the lungs, right? So if I have a just useless piece of lung tissue, but has blood flow going through it, that's the same as if I took blood from my right ventricle and, pumped it through and into my left atria, left ventricle, into my body. So that's when you hyperoxygenate these patients and stimulate the reversal of that, vasoconstriction in those disaffected part of the lung parenchyma, you are going to create that shunt, and you're going to create that shunt in a, pretty rapid fashion. So that can actually lead to, strangely enough, like more CO2 retention, and to a degree, like you will affect hypoxia as well with that. So you're really reversing the body's mechanisms that it has to protect itself.
Yeah. It's analogous to if we had a car accident out on the main road here, they're going to shut down the lanes because it's like, I'm not going to let traffic just go through this damaged air of all these car accidents. That's what your lungs, it's like, why am I going to send a poorly ventilated area of blood that's not going to be utilized that well? So I constrict because the low oxygen levels, I'm going to divert it somewhere else. And then if I give you high concentration oxygen over a long time, you're going to have the reversal of that. So it dilates, but then that causes the mixture in the shunt, leads to CO2 retention. Yeah. But also, like you said, oxygen is a drug. And if I increase oxygen over the 80 to 92 benchmark, that leads to free radical accumulation. So everyone's like, oh, what is these free radicals? I hear it all the time. Eat your blueberries, combat disease and everything. But if you have too much free radicals, think about it like rusting on a pipe. That damage accrues over time and everything. So that's why it's a long-term thing. But that leads to DNA mutations, leads to any disease state, etc. Yeah. But if you have this increased free radicals in the COPD patient over the long term, that just exacerbates the whole condition. That leads to further immune response exacerbated.
Yeah, like we think about, I think over the years we started to realize how oxygen is, a drug that has risks and benefits, and that it's not just some freebie that you get to throw on every patient, because we know that it causes, it can cause atelectasis. Yep. So you're de-recruiting parts of your lung. It causes a shutdown of your type 2 pneumocytes that secrete surfactant. Yep. Do you really want to shut down surfactant in a COPD patient? Probably not. Like lead to even more de-recruiting, right?
Yep.
And we know from like animal studies that, like we talked about this in our Ross podcast, but you put rats on 100% oxygen for 3 days, 100% of them die. So it is a drug. It has risks and benefits, and we need to think about it conscientiously.
Well, let's look from the system lens. I think it's just so easy to put on oxygen. Here, take this high flow mask. I'm going to shoot it up to 15 liters.
Yeah.
That's easy.
Yes.
But you think it's like, this is a drug. I'm going to put on a nasal cannula unless you truly are indicated for high flow.
Yeah.
And I'm going to slowly titrate it up. Because if you do want to give them oxygen, how do we titrate the oxygen levels? Like, how do I achieve 88 to 92?
Yeah, and that's just by starting at the lowest setting that your regulator can give you. You put those CO2 nasal prongs. Obviously, everyone goes for those now, especially in COPD patients, because then I get to measure your CO2, which we'll definitely touch on. But then I can start with 1 liter.
What if I'm on home oxygen?
Okay, then I'll start at 2 liters above your home O2.
So that matches the BLS, and that's empirical evidence. 1 to 2 liters above their own.
Yes.
Because if you're on 2 liters per minute at home, right away, is that a good prognosis? You see that patient on home O2, or is it a poor prognosis?
I'd say that's kind of 2-factor. One is obviously they're at a quite advanced stage of disease, because we know it's a disease of CO2 and not O2. So if they're at the point where they need home O2, they're very sick. But also, I'm happy to see that they're actually using their home O2, hopefully every day. Then they're decreasing their chances of cor pulmonale, all those other issues. So, it's kind of a 2-factor thing there, that they're probably followed really, quite well. And a lot of their chronic care is good, but also that they've, progressed to that stage.
That's exactly right. Now let's flip it.
Yeah.
If the hypoxic drive's so real, why aren't people dying at home of home O2 oxygen?
It's a great point. Yeah. Yeah.
Because there is criteria, very good criteria. Brilliant physicians go through these patients. It's like, are your SATs low? Is your partial pressure of oxygen below this value? They assess the whole patient and be like, yeah, you need home O2 to thrive. Like, you will die if you don't get oxygen.
Yeah, and I think that's something that, from a patient education standpoint, telling them like we want you to take this drug like every other drug every day, no matter how you feel.
Yeah.
Right. This is not about just taking it when you feel really awful. They need to use it when they're sleeping. They need to use it when they're walking around the house and when they're sitting there, because we want to prevent that a chronic hypoxic pulmonary vasoconstriction from affecting their right heart and causing like the right heart hypertrophy that then causes cor pulmonale and other systemic issues, right? So I think that's really important to connect that link.
And cor pulmonale, every paramedic loves cor pulmonale. Probably not. But why does HPV lead to this hypertrophy of the right ventricle?
Right. So yeah, our LV is a really strong, jacked ventricle that's designed to push blood through our entire system, right? That is high pressure, whatever your systolic blood pressure is. And then your RV is our body doesn't want to put more effort or more energy into the system than it has to. So a good normal functioning RV with a good normal functioning pulmonary vasculature is going to be much more thin-walled, because it's moving a large volume of blood through a relaxed, open circulation of the lungs. And, you have your negative intrathoracic pressure, you take a deep breath that even further supports that RV. So it's not used to having to lift big weights and pushing blood through there. But I have all this hypoxia, all this disease going on in the lungs that causes that HPV, and then my RV needs to push through that. And over a long time, like any other muscle, as we hope, will grow. Unfortunately, our ventricles don't grow out; they grow in. So then you end up with heart failure with preserved ejection fraction, and fluid backup that'll go into the venous system. So that'll be, our pitting edema, our increased JVP, things like that.
I think that's so cool to compare. Like, if you go to the gym, work out your biceps, you have an adaptive response to it for the pressure you're putting on. Muscle grows outwards, but the heart muscle grows inwards. So you're enlarging muscle, but you're reducing your chamber size.
Exactly.
And that's like, oh, correct. Like, it's so counterintuitive, but it's adapting to the stressor it's put under, but in a maladaptive way. So that makes a lot of sense when it's explained that way. But also, if you think about the blue bloaters,
yeah,
not the best term, but why do they turn blue?
So that's hypoxia.
Yeah.
My understanding.
Yeah.
And the bloating is from the cor pulmonale.
Yeah. And if you get lack of oxygen, and 98% of our oxygen's bound to hemoglobin, your body's going to be like, ooh, you need to produce more red blood cells, man. But then you're producing more red blood cells to carry oxygen, but oxygen is deprived in this state. So then it leads to subsequent or hypoxia.
Yeah, more red blood cells that are also deoxygenated.
So that's potentially why it could happen with that. Then one of the mainstream treatments that I love this device, it's one of the best things we ever got in the pre-hospital setting, is CPAP.
Yeah.
So we mentioned a brief in that. Why is CPAP so good for outcomes?
Well, so interestingly, before CPAP came along, ACPs did a lot more nasotracheal intubations, fortunately for these patients. And that's because they got so profoundly hypoxic, but mainly so profoundly hypercarbic, which is so like high CO2, which caused like hypercarbic encephalopathy. The patients became super obtunded, not managing their airway anymore, and then you had to intubate them. And, in theory, you can intubate them through their nose, which would allow them to be more comfortable with it. I've never done this before, thankfully, and that's because of CPAP. So when we provide CPAP upstream and early for these patients, we can significantly reduce the probability that they're going to require intubation,
That's right.
especially combined with our short-acting beta agonists and our steroids.
So that's key. We can still provide salbutamol during CPAP.
You have to.
You have to.
Yes.
Because it's a multimodal approach to the disease, bronchodilator, steroid, then you have something that splints open your airways. Like imagine you just did salbutamol. You're only treating one aspect of the disease when you need multiple aspects to be treated.
Yeah.
Then I hear commonly, should I break the seal for the CPAP to give the Dex? The answer is
Please.
yeah, please, they need it. And by the time you rip off the mask and squirt it in their mouth, that's seconds of time. The pressure will decrease enough that they decompensate in the vast majority of circumstances. So yeah, that's why it's important we talked about the patho, each stage of the disease, and how each treatment kind of looks at the different side of it.
Mm-hmm. Mm-hmm.
From the CP side of things, how would they treat these patients at home?
Right. So obviously with that comes a broader like formulary of medications that can be administered with like the cooperative work with the patient's GP. So they can monitor these patients, look for signs that an exacerbation is coming, look for signs that a respiratory infection might be developing, because we know that's the most common cause of these exacerbations. And then we can, get on top of it early, which will involve early antibiotic administration and early PO steroid administration often for these patients, right? But then the most high yield thing is make sure that these patients are vaccinated with the regular flu vaccine, well, typically the high dose flu vaccine, and then also that they're going to be vaccinated for COVID now. We have to do that on a regular basis as well. So those are the main things that I think a CP can really do for these patients, along with, those spirometry measurements and peak flow. You can trend peak flow over time for that patient as long as they're using the test appropriately and see if things are changing for that.
Because then it goes back to the beginning. They're prone to hospitalizations, even from common cold viruses, because they have suppressed immune systems, they're vulnerable. So if you give them the vaccinations, you dramatically reduce the chance of them going to the hospital and suffering worse outcomes.
Yeah.
Because you'll still have mild symptoms, and mild symptoms means you don't have to have a healthcare provider treating them for the most part. Moderate to severe illness means you have to be hospitalized or see somebody as a healthcare provider to treat your exacerbation. So that's the key difference. Like you'll dramatically save the healthcare system and these patients some morbidity and mortality.
Yeah, I guess that's really good for like the chronic management. We touched a little bit on the acute management. And then I really wanted to focus in on the CO2, so that we do monitor end-tidal CO2 in these patients, right? When we're administering that oxygen. Now, do I want to target a normal CO2 value of 35 to 45 in these patients?
No, it's 50 to 60.
Right. If I show up at their home and their CO2 is 90 and I bring it, yeah, okay, sure, freak out. But like maybe their CO2 every day is like 70.
Yeah.
So then if I need to provide ventilation to these patients, which is obviously they're very, very ill if I have to provide ventilation, and I target a normal CO2 of these patients, which, paramedics are very good at hyperventilating patients.
Imagine you see the shark fin pattern on that and you say, yeah, like their end tidal is 70. And you see the shark fin, like what does the shark fin represent?
Yeah, so that shark fin, or like curtailed kind of expiratory phase of the ETCO2 waveform, just indicates obstruction.
Yeah.
So instead of having like a clean exhalatory line, so like just straight up, that beautiful like 4-point waveform that we're looking for, that phase of the respiratory cycle is prolonged, so it looks like shark's fin. Which I think is really cool when we're treating these patients, because then that there's a degree of like airflow resistance that you can treat with your salbutamol. So then you can administer that medication and look for changes in the morphology of that wave, right? And then in terms of what CO2 we're targeting, one of the key things with these patients, right? If we remember our ABG training from school, where you can have a patient with chronic pulmonary disease, they're going to have high CO2, but then their body will respond to that with their metabolic compensation, right? So they're going to have high bicarbs. But then if I shoot down their CO2, and especially if like the in-hospital team continues this and puts their CO2 at like 35 for 2 weeks, now their bicarbs are going to get dumped, and it will be much harder for them to readapt and find that equilibrium again, which makes it harder for the team to like wean them off ventilation and things like that.
Thank you very much for watching. This podcast is all educational and just for support. Please follow local medical directives, protocols, and this is overall not medical advice.